Everybody's letting know before we start. I need you.
Okay. Good evening, everyone.
Okay.
We want to say thank you for being here. I love the way you all just come in and sit down, just kind of like we're doing a jigsaw puzzle or something, trying to find out where you fit. But we are honored that you've chosen to spend this time with us this evening, and hope that you find that being here, it will be meaningful. It is certainly our desire to speak to you in terms of give you an opportunity to tell us what your thoughts are as it relates to the issues that have been mentioned. So mainly the first one is Medicaid expansion. But before we get started, we're going to ask Dr. Walker, who is the pastor of this church. I would ask you to give a round of applause to him and his his members and officers for being gracious and opening the doors for us. So Dr. Walker, if you would come forward, please. Thank you.
Well, welcome to Church Street. We're glad you're here. And let me just let you know, men's restroom in the foyer is to the right, ladies to the left, and then there are restrooms down the hall out to the left. So we're glad you're here. Let us pray. Gracious God, we are certainly thankful for the gift of this day and the gift of life, the responsibilities that you give us as citizens of this community and state and nation, to participate in the process of being informed and participate in voting and participating, knowing the things that we need to know in order to make the appropriate decisions. We thank you for the leadership that's provided here tonight in both of these representatives. We ask that you continue to bless them and endue them with your presence. Give us wisdom as we continue to fulfill the purpose that you have provided for us in this generation. This we ask in Jesus' name. Amen.
Good evening. It is certainly indeed an honor to be here. First, want to thank Pastor Walker for allowing us to be able to enjoy this beautiful church, and certainly and thank him for that. And thank all of you for coming. One of the topics that we're going to begin with, you've heard a lot about this topic, but today we're going to have a discussion in a different way. Instead of hearing it from Representative Hull and I, we want to make certain that you hear it from a hospital administrator to be able to explain to you as to how this impacts our hospitals, how it has already impacted the hospitals that have closed. As you know, there are 13 hospitals that have closed. There are 21 hospitals that are in the same financial condition that are slated to close if we don't do something about this particular issue. And oftentimes, most of the time, it has an impact more on a lot of our rural areas. And you know, when a hospital closes, so does a lot of industry. Industry have to be close to a hospital in order to really move to a community. And so that's something that's extremely important. And so he's going to give us the understanding of Medicaid 101 so that he's one that can lower the hay for everyone, including giving me information that, you know, I probably don't have access to. And so without further ado, we have the CEO of the Huntsville Hospital, Decatur, Mr. Nat Richardson.
Thank you, Representative. I do appreciate Representative Hall and Daniel for you all to be here and allow us the opportunity to have this discussion, because it's a very important discussion. And for that to be an important part on your agenda, it just tells me how important the citizens' health is to you all. So I appreciate you all giving us this forum to have an opportunity to discuss it. I will share a lot of things about Medicaid and why it's important to expand, but I want to give you some information that you may and may not know, and I'll ask you a few questions because I think those questions are pertinent to the information that I'll provide for you. How many of you all know that the state of Alabama is the lowest reimbursed state in the nation, including less than Puerto Rico, for health care? Just a few hands. That's probably less than 0.1% of the citizens that are here. So I'll share with you that Alabama is the lowest reimbursed state in the nation, including lower than Puerto Rico. Puerto Rico gets 25% more for healthcare services than we do. California, there's 22 counties in California that has 3 times the reimbursement that we get for the exact same procedures that we perform at Huntsville Hospital, Athens Limestone, any of our hospitals. So if you had a kidney procedure here in Huntsville, California is going to get 3 times what we get paid. So this, I preference that first because it's important that you understand how we got reimbursed way before the Medicaid expansion importance, because we've always been just on the bottom end as far as healthcare. And the way that works, they have a system that has been in place for many, many years, and it was designed to try to help look at acuity and how different states take care of different individuals. It tried to account for socioeconomic demographics and those types of things, so that if an area was taking more care of individuals with cardiovascular disease, it would improve the payment. And for those areas that had general medicine care that had a higher percentage, those particular states would get a lower reimbursement. Well, that system over time evolved, and it has not kept up with how the states have evolved. And that's been the biggest problem with the formula that they utilize, and that's why we have always stayed on the bottom. The way the federal government system works is a zero-sum game, and what that means is for Alabama to get more money, a state like California, a state like North Dakota, even Puerto Rico would have to get less. They don't put more money in the pot. In order for one state to get more money, another state has to get less. Well, when you look at the delegates in the state of California, I doubt very seriously with the political power that they have, we're going to be able to get Nancy Pelosi to give up any of her money for her state. It's just not going to happen. So how do we level the playing field? Well, we've worked with most of our state representatives because it's not a state issue, it's a federal issue. And we've got to have individuals that's on the federal level. Senator Shelby, we've had various discussions with him to try to help him create what we call a floor, so that no matter what state you're in, your reimbursement is no less than, let's say, a 0.78% payment against that model that they utilize. Right now, we are at a 0.6849. I think that's the number. And all of the other states are at least at a 0.80. It's hard to take care of the patients like we want to take care of patients when you have such low reimbursement. We still have to pay our nurses no different than the nurses in California. A nurse is not going to come here and accept $15 an hour. Nurses, they're going to get paid a national rate. So we're still having to pay nurses, the techs, and all of those team members that are a part of the healthcare system. We have to pay them market rate if we want the best of the best. So the lowest reimbursement, and we still have the same cost structure, no different than some of the other major states out there that are getting twice the reimbursement. So Medicaid expansion, why is that so important in our state? For Huntsville Hospital System, we write off about $13 million a month for individuals who don't have insurance. Okay, now, there's a lot of reasons they don't have the insurance. Some of them, they make just a little bit too much for the federal poverty level, and they can't afford the premiums. There's a lot of individuals who will not pay their co-pays and deductibles, and we have to write that off after a certain period of time that they haven't paid. And this is a funny, but it's real. Many of those individuals who don't pay their co-pays, you'll see them riding down 565 and 65 with jet skis on the back, and then they tell us they can't pay their co-pays and deductibles. And when you're treating as many patients as we treat, all you have to do is get a lot of those individuals who don't pay their co-pays or deductibles, and it starts to add up. So that's a second part of that 13 million. And then that third part is just individuals who have decided, I'm not going to get health care insurance, because with all of the changes from the Affordable Care Act, one of the changes that the Congress that we have now has made is you're no longer penalized if you don't have health care insurance. So what do you think those individuals who really didn't want it but didn't want to be penalized did? They dropped their insurance because they're not going to get penalized for it. So that was an important piece of legislation at the federal level that impacted your hospitals and your community hospitals. So I'm going to talk about some of the rural hospitals first. They are really struggling, as Representative Daniels stated. Those hospitals are in a lot of trouble because they operate on thin margins. Most of your rural hospitals are what we call bread and butter in our language. They do general medicine. You're not going to go there and have open heart surgery, open brain surgery, or anything like that. So with us being reimbursed so low, they need a lot of volume for general medicine. And guess what? General medicine is paid at the lowest level because that's kind of basic medicine. And as you get into cardiovascular medicine, neurology, any of the gastroenterology procedures, you get more for those types of things, but a lot of the rural hospitals are not able to offer those services. So you have a regional healthcare system like Huntsville that's kind of the hub. Everything gets sent there that can't be done out in the rural hospitals. But if the rural hospitals are not getting reimbursed for those things that they need to keep their hospital open, they end up closing. And that's one of the reasons why it's so important for your rural hospitals, is because of bread and butter medicine, low reimbursement, not a whole lot of volume on those dynamic procedures and those procedures that really reimburse at a higher level. And you really don't want that. I wouldn't want a cardiovascular surgeon performing surgery on me that only does 2 a month. So you really want that in a high volume place. But for those other hospitals that are rural and they really need to be out in those communities, we've got to figure out a way to make sure any person that they treat, or most of the people that they treat, they get some type of reimbursement. That's where the expansion comes in. If we can expand Medicaid and have more people insured, we're not taking care of a lot of those individuals who come to the emergency room, and the average emergency room visit is probably $5,000 or $6,000. And add that up times so many individuals that don't have the insurance, and you see why these hospitals start to close. But those hospitals are very, very important to our infrastructure, because if we don't have hospitals in the rural areas, they don't get care fast enough. Some people lose hope, and they don't come in for care. And when they lose hope and don't come in for care, when they get to a big tertiary center like Huntsville, they have so many comorbidities that we're trying to treat, it just makes the healthcare system extremely expensive. For Huntsville, one of the things that they've tried to do is, for instance, Decatur. Now, I'm a Huntsville Hospital employee, but I'm responsible for the Decatur operations. And when I went out to Decatur about 7.5 years ago, they were losing $10 million a year. A lot of their losses was attributed to individuals who didn't have insurance. They'd go to the emergency room for their primary care. So someone is going into the emergency room for a cold or a sniff, and we may spend $3,000 or $4,000 just trying to figure out what's going on with them. We need those hospitals that have the rural settings to have primary care physicians in those hospitals so that they can see those patients, and when they need more acute or chronic care, they come into the tertiary center. And if we can get Medicaid expanded so that those hospitals get reimbursed more for those individuals that are not insured, that's what's going to help the rural areas. Now you get back into suburban and urban. The reason why it's important is because Huntsville kind of supports all of those other rural hospitals that are part of our system. And so, for instance, we have 13 facilities that's part of our system. I don't know if you all are familiar with Helen Keller Hospital, Red Bay Hospital, Athens Limestone Hospital, Decatur West, which is the psychiatric hospital, Parkway, which is the hospital on the Beltline in Decatur. You have Decatur Hospital, the main big hospital, which is in southeast Decatur by the school. You have Marshall North and South, Huntsville Hospital for Women and Children, and then we have an affiliate with Fayetteville Hospital in Fayetteville, Tennessee, and a couple of other affiliates as for surgery centers and things like that. So all of those hospitals pretty much struggle when you look at their income statement. They're running in the red, and anytime we can get the volume in Huntsville and make sure that those are insured, Huntsville can kind of help support those other facilities to stay open. So why haven't we been able to expand Medicaid? It's like anything else in the world, it's all about money. I'll explain to you the Medicaid expansion, how it was originally designed, but I think we've waited too long to become a part of the original design. The way the government designed that program, the first 3 years of Medicaid expansion was basically covered at 100%. 3.5 to 4 years, the government took care of it. In year 4, the government says, we're going to fund 90%, and you've got to come up with 10%. You, meaning the state of Alabama. That's where the problem lies. Where do we get the 10% to fund that balance of the Medicaid expansion patients? And that's where we've had a challenge. You have your general fund budget, you have your educational budget. It probably should come out of the general fund, but how do you create more dollars in a general fund to fund that gap? So we understand that, but a lot of other states have done this. And some of them have gone on Medicaid expansion, and some of them are back off Medicaid expansion because they didn't have the right formula to put together and make sure that it was funded. But in a state like Alabama that's already the lowest reimbursed state, if you compile not expanding Medicaid on top of that, you start to get a feel and understanding of why it's so complicated to keep hospitals open. Because they're running on very thin margins as it is. They don't get reimbursed a lot. So that's kind of the whole Medicaid expansion. I hopefully have at least explained to you what the issues are, why they're important, and I'll open it up to questions if you all have any questions. Yes, sir.
Hold up just a moment, please. Hold up.
My question to you is regarding the cost of each hospital visit. Thank you, Ms. Hall. Let's see if this works better. There we go. Thank you. My question is regards to the cost of each hospital visit. Now, you said $5,000, $6,000. Now, I guess I'm one of the lucky ones that have not been to the hospital in a while, but it does sound about right. Yeah. On the federal level, I know there are plans or within the legislature to investigate the cost of high drug prices and all that kind of stuff. My question to you is, from what you see as a health administration professional, what are the steps or the ways, from your experience or from what you see, where this costs that also run into the 10% that you talk about, how can those prices or costs be reduced on a policy level that can be implemented?
Well, one thing that I do believe in with the current administration is competition. I think right now we've got to go after some of the pharmaceutical companies. So for instance, if you look at your hospital bill, the next time you look at a hospital bill, I want you to look at what the hospital charged and what the hospital got paid. And I guarantee you most of the time it's going to be 90% less than what we charged. So you say, well, why do you put all of those crazy charges out there and you charge these people $20,000 and you only get paid $2,000? It's a game that every hospital in the U.S. have had to play. And basically what happens is you have insurance companies, some of them that are still reimbursing us on a percentage of charges. Other insurance companies pay us a flat amount. That's all you get. It doesn't matter how many days they've been in the hospital. It doesn't matter what resources you have utilized. They look at the number of procedures. They do a national average, and that's what you get. So to help balance what we don't get on the low end, we have to put our charges up here so that we get a higher percentage of those charges to help fund and offset those other insurance companies that are being subsidized and the other payers that are being subsidized. But I think competition is one. I think, two, many hospitals, as you may know, are getting into the supply chain, meaning developing their own pharmaceuticals or having their own solutions developed from within the house. I think that will help. And I think some legislation. We've got to help from the legislators and get away from so many of the lobbyists who go to the legislators and they just continue to charge.
Can you talk about how the DISH payment cuts are also related to all of this?
Sure. So DISH payments is a payment by the federal government that they would give hospitals for taking care of those individuals who don't have insurance. However, DISH payments went away with the Affordable Care Act. Now, we're still getting some from last year, but starting next year, the DISH payments will stop. And the reason why they stopped DISH payments is because they said, if you expand it and you're getting paid for all of those individuals who didn't have insurance, then you don't need the DISH payments. Well, guess what? Alabama did not expand. So we get a double whammy. We don't get the DISH payments anymore starting in October, and we've not expanded. So we still will be taking care of all of those individuals who didn't have insurance. And we're going to lose about another $6 million from payments from the DISH side that we would have gotten, because that is money that they rolled into the Affordable Care Act to help pay for that portion. Make sense?
When you talk about the reimbursement rates for the state of Alabama, are you just referring to Medicaid, or are you also referring to commercial insurance and Medicare? Our
Blue
payments
Cross
are-
Blue Shield, United Health, Aetna, Medicaid, Medicare, all of the payers, if you look at their payments in all of the other states, we get reimbursed the least amount.
And part of that would be like a commercial insurance or Blue Cross problem, right?
That's correct.
Yeah, it's not
the
totally.
commercial side.
Right.
And when they had the Cahaba side, Blue Cross used to have a division called Cahaba, which was the fiscal intermediary for the state of Alabama, managing Medicaid and Medicare. So they had control of that, and they had control of their commercial side,
Yeah.
which also reimbursed us less.
I mean, I think that's an issue in addition to, so my second question, what was my second question? My second question was about, oh yeah, I know. Have any studies been done on the economic impact in terms of jobs created by the Medicaid expansion? And wouldn't that offset the $1 that we would have to pay for every 9 that we would receive for the federal government if we took the Medicaid expansion, which we desperately need to do so?
Maybe just because how you said that. Yeah. We've said that 100,000 times. I bet exactly as you stated it, just the economic impact alone should be worth it to our state, but we have just not been able to make the ground that we need to make with our elected officials to get them to understand that, yeah, you got 10% gap on this end, but how do we work together and fill that gap, but also get the benefit of the economic impact? But yes, we have made that argument.
Richard Alexander, have you considered offering they tried it in Tennessee, it didn't work, but the hospitals got together and said they would pay that copay because ultimately the amount of money they were losing, it was worth paying it. Have you considered offering that? Not that it would work, because it's other issues there.
Right, yeah, we have, and you have two issues there. You have your for-profit systems who they're funded a little bit different than the nonprofit system, so we're gonna have to fix that piece first. And I don't know if you all are aware, but the money that we get for Medicaid in the state of Alabama is 100% funded by the hospitals. Were you aware of that? Okay, so let me tell you how it works. So basically, all the hospitals have to put into a pool. That pool of money goes up to the federal government. They match that pool of money. Then it's brought back down to the state, and then it's distributed to hospitals. But all of the hospitals in the state, including for-profits, they're the ones that's putting the money in that pool to draw the money down 2-to-1 from the federal government. And we've done that for years. Your question would be, how do we expand that and maybe put more money into the pool to kind of help fund that 10% gap? Yes, sir.
Well, the audience back here.
From looking back, in hindsight, we know what the Affordable Care Act, how people in Alabama would have benefited from it, and we know about how many people have died because they did not have access to Affordable Care Act. So looking back, can you say now that Alabama is better off for not expanding it or worse off for not expanding it?
Well, I'll say this. I think economically, we would have had a greater advantage because we could have created more jobs. I do believe that many of the hospitals that have closed, I'm not going to say that all of them would have stayed open, but anytime you can keep hospitals open, especially in rural areas, will give you access. And that's kind of what I talked about earlier. If you don't have access to health care, sometimes you're just not going to go for it. You just won't go to try to get treatment, because if it's 50 miles down the road, well, maybe that doesn't hurt so bad, I'll be okay. And then before you know it, that disease has transitioned into 2 or 3 different comorbidities, sometimes 6 or 7. And by the time they get to a tertiary major medical center, you're spending hundreds of thousands of dollars just trying to maintain their health. But I do believe that there's a lot of advantages. We would have had more advantages with the Affordable Care Act than not.
It seems to me part of the argument has to be for the whole state that even if you don't want to be concerned about some of these rural communities and the struggles that they're now having because of the hospitals being closed, and of course I think we all should be concerned, but even if we don't want to be concerned, we should have a selfish reason for wanting these hospitals to stay open, and that is, as the rest of us travel through the state and are in these rural areas, what's going to happen to us if we have a serious accident? What's going to happen to us if we have a health crisis and there are depleted medical resources, closed hospitals, et cetera, because we can't access them because of what's happened?
I need to take you to some of the meetings with me. Great comments, and I appreciate that.
Hi, I'm Kathy Jones. One of the things that I looked at about a couple of years ago was the statistics of mortality rates in Alabama versus the rest of the country, and some of the major reasons for the I guess premature deaths of a lot of the state citizens. And it looked like most of them were things that could have been addressed by preventative health care early on, which when you said that earlier, it resonated, because you've got to be able to have access to health care in order to prevent, to be able to detect health issues early on. And I guess I actually took my concerns to Mo Brooks, and he just said, well, you have anything better? And that was his response. And I felt like it was pretty heartless. But I guess I'm just thinking that, is there something that you can look at that sees, is there anything but more recent data? I mean, this public health department, their data is a few years out of date, but are you starting to see any kind of effect of all the hospitals closing?
I would say the biggest effect that we're seeing is now those communities that don't have a healthcare facility, number one, they're having to drive a lot further. Number two, they're coming into the emergency department. We really don't need to take care of primary care in the emergency department. Those need to be designated for those individuals that truly have an emergency. I'll give you an example. We saw about 170 patients in our emergency department last night, and that's over a 24-hour period of time. But at the end of last night, we saw 174 patients. 92% of those patients could have been seen in a primary care office, because we have to code them out at a certain level, and the emergency codes go from 1 to 5, 5 being the highest level of care, 1 being the lowest level of care. And 93% of those visits were level 1s that could have been seen in a primary care office. So we have to make sure that we take care of the rural areas and make sure that those citizens in those areas have access to primary care.